atypical iris and cilia choroidal coloboma, persistent fetal vasculature, and congenital cataract. A 5-year-old female presented to us with poor vision in both eyes since birth. Small right eye since birth and whitish reflex noted in the left eye noted 6 months back. On clinical examination, the left eye showed cataractus lens with anterior capsular plaque and an atypical iris coloboma in the infratemporal quadrant. The right eye was microphthalmic. The B-scan USG of the left eye showed temporal coloboma with taut retina adjacent to the coloboma. This is the clinical picture of the left eye showing 1. Cataract with anterior capsular plaque. 2. Atypical iris coloboma involving infratemporal quadrant. 3. Some abnormal pigmentation can be noted around the equator of the lens in the area of iris coloboma. 4. Supernasal quadrant of the limbus shows localized sclerocornea. This can be confirmed by microscope integrated OCT where irregular scleral lamella can be seen to continue into the cornea. 5. Few flimsy posterior synechiae can be noted. Ultrasound biomicroscopy showed cataractus lens with focal lenticular defect temporally giving a picture of cookie bite. After making 3 side ports and staining the anterior capsule with 0.06% trypan blue dye for 10 seconds, the anterior capsulotomy was done using microvitreoretinal blade. The edges of the stabbed incisions were joined with the micro scissors. Anterior capsular plaque was removed with a forceps. After a gentle hydrodissection, bimanual lens aspiration was done using cutter at eye cut mode. After removing the opacified cortical lamella, we found new surprises. Extensively vascularized uveal tissue could be seen bracketing the nasal and temporal lens equator. In addition, a central PFV stalk was noticed. The vasculature bracketing the lens can be clearly seen to be in continuation with a central persistent hyaloid artery. On zooming up, blood flow can be seen through the vessels bracketing the lens. This is a rare and atypical picture of persistent fetal vasculature, where we can see the prominent persistent tunica vasculosalentis. A posterior capsular hixis was done, and a clot of fresh vitreous hemorrhage was noted. The central stalk was diaphragmized and cut using microscissors. A good anterior vitrectomy was done. Intraoperative fundus evaluation shows 2 atypical colobomas around the disc, and the PFV stalk was seen to arise from one of the colobomas. Dispersed vitreous hemorrhage could be noted. The blood flow can still be seen through the vessels of persistent tunica vasculosalentis. The wound was enlarged, and a 3-piece IOL was inserted into the sulcus, and an optic capture was done. The main wound was sutured. Viscoelastic was aspirated and the wound was sealed. The clinical presentation of this patient lies in the spectrum of microphthalmia, anophthalmia, and coloboma syndrome. MAC syndrome has a complex etiology. The disease could be due to monogenic mutations of SOX2, ATEX2, and STRA6 gene, chromosomal anomalies, and environmental factors such as maternal infections, maternal vitamin A deficiency, and antenatal exposure to teratogenic drugs can also be causative. The overall prognosis is usually poor. In patients with associated cataracts, a timely intervention may rescue some vision. Most cases might need further intervention by a vitreoretinal surgeon. Thank you.